Hello, and welcome to this brief webinar on evidence-based practice in applied behavior analysis. I am Dr. Jason Hirst, and I am a BCBA at our McKinney office. Let's talk about our agenda for the day. First, I'll talk about what evidence-based practice is and what it means, how we can sort good information from bad information, and what evidence-based practice looks like specifically for an ABA service provider. What's in a name? There are many terms that you might hear practitioners use to describe the evidence behind their practices. So you might hear someone refer to their practice as empirically supported, scientifically validated, research supported, or evidence-based. Evidence-based practice is supposed to be the highest standard of evidence behind a practice. But the use of these terms are really all getting at the same question, and that is there enough support to continue using this method in practice? So that's really the important question. Although evidence-based is supposed to indicate the highest standard of evidence, there isn't one fixed definition for what evidence-based means because it depends upon the criteria that you're using to define it. Several different organizations, including the American Psychological Association, the Association for Behavior Analysis International, the What Works Clearinghouse, which is a database of educational interventions maintained by the Department of Education, and even the Behavior Analyst Certification Board have different criteria that they use to define evidence-based practice. Despite differences across organizations, there are some recurring themes in what those criteria dictate. So the first one is quantity. In order for something to be considered evidence-based practice, there need to be several studies that involve many participants. It's usually not sufficient for one study to indicate that a practice is evidence-based. Things that have at least one research study in support of them can be called empirically supported or research-based even, but not evidence-based. It's also important that across multiple studies, there is a certain number of participants involved in those studies because we want to see that this method is not just effective for one person or a couple of people, but actually many. The second criterion is quality. So we want to make sure that the studies that are published are of high scientific rigor and demonstrate effective experimental control. This is generally controlled by the peer review process in academic journals. So before research gets published, it gets sent to other scientists who read the study and review it for its scientific rigor. The third criterion is spanning the continuum from efficacy to effectiveness. Those are terms that might sometimes be used interchangeably, but there's an important difference between them. Efficacy refers to the effectiveness of a procedure under highly controlled laboratory settings or ideal conditions. So that is, efficacy is answering the question of whether something can work under ideal circumstances, whereas effectiveness actually more represents whether a procedure or method is effective when implemented in the real world with less control. And then finally, we want to see replication, which is actually related to quantity, but there's multiple dimensions of replication that are important to us. So we want to see that replication of the effectiveness of the method across people, across places, and across researchers. Evidence actually is only one component of a three-component model of evidence-based practice. So even after you've identified that a procedure has sufficient evidence in support of it, we still need to look at the other two components. So the other two components are clinical judgment and context. So all three of those things need to be present for something to be considered evidence-based practice. With respect to the evidence, it's difficult for the average person to collect and gather and sort and evaluate evidence. The first thing you can do is actually just consider the source of your information. So we know that personal experience and anecdote and testimonial, and even sometimes authority, are subject to bias and error. science is really the only source of information that we can generally rely upon. Even if science gets things wrong every once in a while, the cool thing about the scientific method is that science will be the first source of information to admit when it's wrong about something. So science is constantly shifting and is maintaining an open mind about what is true and what is not. Most people will have difficulty accessing scientific research because academic journals are usually behind a paywall. There are some open access journals available to the public, but most journals operate on a subscription model. Many factors influencing confidence in results published in academic journals are not readily apparent to most readers. So, in addition to gaining access to the articles themselves, you would also want to look at things like who published the study, what vested interest might they have in the results of that study, who were the reviewers, what journal was it published in, and what are their standards. So those are not things that are readily apparent to the general public. Many resources, however, are publicly available that will help you to either gather information directly from research studies. All federally funded research is required to be published on a database called PubMed Central. I'll have a link to that database in the resources slide at the end of this presentation. But you can also use other organizations whose mission actually involves gathering evidence and information and presenting it to the public in a way that is easily digestible. So those organizations include Autism Speaks, the National Autism Project, and the Association for Science and Autism Treatment. I'll talk briefly about the National Standards Project, which is currently to date the largest comprehensive literature review of the intervention literature. It was conducted by the National Autism Center, who applied the scientific merit rating scale that they developed to all of the evidence they could find, either in support or not in support of interventions for treating autism. So they looked at the type of research design, the number of participants who were served, what kinds of data were collected, whether procedural fidelity was assessed. The diagnosis of participants was confirmed in each of these studies to ensure that the studies were looking at individuals who genuinely had a diagnosis of autism. And they looked at the effects of the interventions and whether those effects maintained over time and generalized across settings, contexts, et cetera, appropriately. In order to be called an established intervention, a intervention had to have at least 2 group design studies, which are usually your pre-test, post-test, large group studies, or 4 within subject studies, which tend to involve fewer participants in each study. But across all of the studies that were published, there had to be at least 12 participants. And probably the largest hurdle was that there couldn't be any conflicting results also published in the literature. So even if a particular approach had a lot of support in the literature, the presence of conflicting results would automatically disqualify it from being called an established intervention. To summarize the conclusions of this very large project, they identified 14 established interventions for autism. And I'll just kind of highlight here in green the approaches that are consistent with applied behavior analysis. So when you hear that applied behavior analysis is evidence-based practice for the treatment of autism, this is part of the evidence that we are referring to. The study also identified several intervention approaches that are not established. It's important to understand that some of the interventions on this list have research-supported uses for other disorders. So, for example, a gluten and casein-free diet is appropriate for individuals who have gluten or casein sensitivities, but that a gluten and casein-free diet is not an established intervention for treating the core symptoms of autism. One of the interesting things that I actually have some personal experience doing research in is animal-assisted therapy. It would be a really cool idea to think that swimming with dolphins or riding horses could treat the core symptoms of autism. But what the research shows is that although children with autism really enjoy interacting with animals, animal-assisted therapy has not consistently been shown to treat the core deficits of autism. Um, so it can be used sort of in combination with other procedures, usually as a reward. Children we found will actually work very hard to gain access to interacting with animals, but it was the other procedures that they were going through in order to gain access to the animals that were actually causing the changes in their core symptoms. The next component is professional judgment. So applied behavior analysis is actually a science. It's the applied science of behavior, and not a toolbox. So the rate at which our field is growing kind of means that people being trained in behavior analysis will learn that a certain approach tends to work for children with autism or adults with autism, and they might try to use that same approach across all of their clients. However, no two clients with autism are the same. And the behavior analyst must be an analyst, which means that they must make data-based decisions. They must engage in continuous assessment and evaluation of programs and progress on those programs, and also consider and incorporate individual differences. So just because something worked for one particular client, or just because one research study says that something could be effective, doesn't mean that that's the right approach for an individual client. We have to practice our professional judgment. The third component is client values. So programming must be individualized for every client in order to be considered evidence-based practice. And individualization means that we're looking at whether our programs, the skills that we're working on, are developmentally appropriate for that person, are consistent with their cultural values, that the skills we are teaching are functional for that individual, and that the skills are socially valid. So functional meaning that before we teach something exotic, we want to make sure that we're teaching that child things that they're coming into contact with and skills that they'll use on a daily basis. An interesting metaphor, and I forget who coined it, is horses before zebras. That it's much more likely that the child will encounter horses before they encounter zebras. So although zebras are interesting, you don't necessarily want to teach about zebras before the client learns about things that are going to be more proximal to their everyday environment. And socially valid skills are things that caregivers value, that society at large values and thinks are important. So we're not going to teach a skill just for the sake of teaching that skill, but rather we have to pay attention to what the client's family and their immediate community feel are important for them to learn. So clinical judgment and applying context to our caseload is a skill that must be learned. People who are credentialed to work with individuals with autism tend to hold a credential called the Board Certified Behavior Analyst credential. I am myself a doctoral level Board Certified Behavior Analyst. But what is a BCBA? So a BCBA is someone who has passed the credentialing requirements set in place by the Behavior Analyst Certification Board. Not all BCBAs are created equal, unfortunately, and the same applies to the therapists that are called registered behavior technicians. So let's just take a quick look about what being a BCBA means so that you can better understand what it means when your provider has that credential. So a BCBA credential is earned by earning a master's degree in a related field, or actually any field in the future. The Behavior Analyst Certification Board is removing the related field requirement, but it must be from an accredited institution, so it can't just be any old master's degree. That person must also complete 270 hours of approved graduate coursework in behavior analysis. that may or may not be part of their master's degree. So if they have a master's degree in behavior analysis, that might also encompass the 270 hours of graduate coursework. That person must then accrue 1,500 hours of supervised clinical experience with someone who is currently credentialed. And then finally, the last sort of hurdle is passing a 150 question multiple choice exam. So although these are certainly not easy standards to meet, they are also not standards that indicate that someone is totally done learning about the discipline of behavior analysis. The BCBA credential is the minimum standard that someone must meet in order to practice behavior analysis independent of supervision from another professional. I'll also mention that all BCBAs are required to continue learning about their discipline of behavior analysis by earning 32 hours of continuing education every 2 years in order to maintain their certification. So a BCBA credential is, again, so it's sort of the starting point for a professional in this discipline. Someone who earns the BCBA credential should be making a commitment to being a lifelong learner. And so, really experience is an important aspect of the quality of services that a BCBA will be able to deliver. So let's look at how you can recognize evidence-based practice with an ABA service provider. These criteria were set forth by the Council of Autism Service Providers, or CASP. I'll also have a link to that resource on the last slide here. So in order to call something ABA and to call it evidence-based practice in ABA, you need to see 4 things in the treatment approach that's being used. The first thing is objective assessment and analysis of a client's condition by observing how the environment affects the client's behavior as evidenced through appropriate data collection. So the first thing that you want to look for in a provider is that they are collecting objective data on behavior and how that behavior interacts with the client's environment. That's important because in order for something to be called ABA, we're not going to be talking about internal states and traits of the individual. We're not talking about their mental condition, but rather their observable behavior and how that behavior affects their environment and how the environment then in turn affects their future behavior. The second criterion is importance given to understanding the context of behavior and the behavior's value to the individual, family, and the community. So this standard actually kind of talks about a couple things. First, that it's talking about context of the behavior. So that is the environment in which the behavior occurs, but also the behavior's value to the individual, family, and community. So it's again talking about that social validity criteria. The behavior has value, either desirable value or value, or negative value as an undesirable behavior, specifically for that individual, family, and the community in which they live. The third one is important. We're looking for utilization of the principles and procedures of behavior analysis such that the client's health, independence, and quality of life are improved. There are several principles in behavior analysis that we have to be able to see in the practice of applied behavior analysis. So we need to see that reinforcement is being used. We need to see that the client is being provided with appropriate instructions, that their behavior in response to those instructions is either being reinforced or not. And we need to see appropriate generalization and programming for generalization. The provider that you're working with should be providing you with instruction actually as a caregiver. So if you're a caregiver with a child with autism, or if you're the caregiver of an individual, an adult with autism, evidence-based practice dictates that parent training is actually part of this. So the exact principles of behavior analysis are a little bit beyond the scope of this presentation, but you need to be able to see them in the treatment. And what's important about this third criterion is that the procedures, whatever they are, must be effective. So you need to be able to see changes in the client's quality of life. The fourth criterion is consistent, ongoing objective assessment and data analysis to inform clinical decision making. So again, this gets back to the fact that we're always collecting data as behavior analysts. So if you're not seeing, if the provider is not able to share data with you or is unwilling to share data with you, it could be that they are not collecting those data, or maybe the data aren't showing the results that they are hoping for. So we also want to look at keeping the analysis part in applied behavior analysis. So a skilled behavior analyst should be flexible and not rigid. Their practices should be, they should be practicing data-informed clinical judgment. So again, just because a research study can be found that suggests a particular intervention approach is effective for some individuals, doesn't make that approach the right approach for an individual client. We need to make sure that we are, as behavior analysts, using data-informed clinical judgment. We're looking at progress, objective measures of progress, and judging whether the procedures we're using are effective. We also need our treatment plans to be individualized. There are many standardized curricula out there, so you might hear about assessments called the Verbal Behavior Milestones Assessment and Placement Program, or VB-MAP, or the ABLES-R, which stands for Assessment of Basic Language and Learning Skills, revised. They also contain lists of skills that can be taught, so it's sort of a curriculum and a curriculum-based assessment. But that same curriculum is not going to be appropriate for all of our clients. So we really want to use those curricula as guidelines, and really create our own individualized curricula for each of our clients. And then finally, the behavior analyst must keep up with emerging research, but also balance what the literature says with what will actually work for their clients. So again, it's not important whether one research study says that something's effective. We need to know if it's effective for our individual clients. So how can you, as someone outside the agency, consider the quality of services that are being delivered and whether those services constitute evidence-based practice? I've developed a few questions that you can ask a provider. The first one is, what does the intake process entail? So as you approach a provider for the first time, what's the first step? You want to see that there is an objective assessment conducted, that you either bring the client into a center, or the clinician visits your home, or wherever you are in the community, or even the use of clients or caregivers serving as proxies for technicians. Essentially, you want to see that the clinician is doing direct observations and conducting interviews during the intake process. And you want the caregivers to be involved and participate in that assessment, because it's important what clients and caregivers value and what they want to get out of their treatment. So you want to see objective assessment, and you want to see the involvement of the client and caregivers. The second question you might consider asking is, does the treatment plan relate directly to behavioral deficits and excesses identified during the intake process? So it's one thing to conduct an assessment. It's another thing to ensure that the treatment plan that is developed is supported by the results of that assessment. So we can't have a cookie cutter intervention plan. We need that intervention plan to be directly tied to what we observed during the assessment. That is, what skills should be there that aren't, and what behaviors are occurring that are undesirable. Those things should directly inform the development of the plan. Third is, does the provider have a plan in place to ensure progress is monitored continuously? So it can on occasion occur that a program is implemented for a month, 3 months, even 6 months, and the client is not making progress on it because maybe the clinician is overloaded, their caseload is too big, and they're not able to keep their eyes on the data and the objective measures of progress. So that's kind of problematic. We want to make sure that there's a plan in place, that there's capacity for the clinician and their assistants to continuously have eyes on the data, on the graphs, so that they can make sure that we're continuously making progress. A fourth question you can ask is, how are staff trained and are they supervised regularly? Anyone who holds a registered behavior technician credential is actually required to be supervised for a minimum of 5% of their service hours. So if they were working 40 hours a week, they would need to be supervised for 8 of those hours. And then last, will the clinician commit to sharing objective evidence of progress? So you should be meeting with the clinician regularly, and they should be sharing progress that the client is making. And that evidence should be in the form of objective, measurable data and not just sort of subjective or narrative descriptions of progress. And you need to see, if someone is not using language consistently, that now they are using language consistently. If someone was not able to perform a specific self-care task, that now they are able to perform that self-care task. So those things, need to be objective, and you need to see that progress. Well, those are some things that you can use to evaluate the quality of services provided by your ABA service provider. There is quite a bit more information available out there for you to digest. This was sort of kind of an introduction to some questions that you can consider about how good the services are. Here are some resources that you can go to. So the Council for Autism Service Providers, or CASP, is a great resource. It's actually an organization of autism service providers that develops and maintains standards to which we sort of hold ourselves as providers. The National Autism Center, as I mentioned, is the host of the National Standards Project. So you can actually download a copy of the full National Standards Project report from that website. The Cochrane Library is an organization that conducts literature reviews. So they gather together large bodies of research and evaluate whether that body of research is generally in support of a procedure or not. So you can find Cochrane summaries of specific procedures on their website. I mentioned the What Works Clearinghouse, which is a database of evidence-based practice in education maintained by the Department of Education. The Association for Science and Autism Treatment is another great organization that puts out position statements about the relative effectiveness of different approaches to treating autism. Autism Speaks does the same. The Behavior Analyst Certification Board is where you can find information about the credentials, the BCBA credential, the Board Certified Assistant Behavior Analyst credential, and the Registered Behavior Technician credential. The federal database of federally funded research I mentioned is PubMed Central. And a lot of research articles you can actually find by using Google Scholar, which is essentially the Google search engine for academic research. Well, if you have any questions, you can feel free to reach out to us, and I'm sure that we'll be happy to answer your questions.